Hello and welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thanks very much for joining us. I'm Alan Card, a research associate with the center and an assistant professor at the UC San Diego School of Medicine. I'll be your host for today. Before we begin, I'd like to thank the Health Environment's Research and Design Journal for providing free access to the journal articles we review. If you've not already done so, we recommend subscribing to HERD. There's a discount code for attendees to receive 20% off the subscription using the code HERD20, that's HERD20. I'd also like to say thank you to today's EBD Journal Club sponsor, PadCraft. The purpose of the Evidence-Based Design Journal Club is to engage the healthcare design community in dialogue regarding important research to help us better understand the links between the built environment and health-related outcomes and apply it in the real world. I'd now like to introduce you to the authors of the article we're discussing today. First one is Katie Pedito. Katie is a postdoctoral research associate in the Department of Design and Environmental Analysis. Katie received a PhD in Human Behavior and Design from Cornell University in 2019. She previously received a BA in Psychology from St. Mary's College in Maryland, where she completed a capstone thesis on infusion pump keypad design. Her previous experience investigating alarm fatigue at Johns Hopkins Hospital sparked her interest in design research in healthcare settings. At Cornell, her research aims to improve health facilities from vulnerable populations, including adolescents and young adults with cancer. After leading a run from San Francisco to Baltimore in the summer of 2016 with the Ullman Cancer Fund, Katie noticed that AYA patients were often treated in pediatric settings with little access to peer support. Her research investigates the influence of the built environment on social support and quality of life for young people with cancer. This research study won Katie the 2018 New Investigator Award offered by the Center for Health Design's Research Coalition. Brian is a behavioral health planner and architect with the leading healthcare design forum, HDR. He has a deep understanding of current research and trends in behavioral health design and uses his experience to create innovative research-based solutions that improve the patient experience in mental health environments. Brian has served as the behavioral health expert on numerous projects around the world, holding roles in planning, design, and consulting for inpatient, outpatient, community, and educational facilities, guiding project teams toward improved outcomes. At HDR, Brian leads the Behavioral Health Design Studio, introducing current trends and design strategies to broader HDR teams, and works with smaller focus groups, to design and develop strategies to improve the mental health care environment for patients and staff. In addition to building design, Brian works with manufacturers to design and evaluate furniture and accessories for behavioral health environments, focusing on improved safety, comfort, functionality, and aesthetics. He was also recently selected to participate in the FGI 2022 Health Guidelines Revision Committee, focusing on behavioral health design in the emergency department. Thank you very much, Katie and Brian, for joining us today.
Thank you, Alan.
Happy to be here.
Okay.
All right.
And at this point, we will turn it over to you guys. Thank you.
Awesome. We'll take it from here, Alan. Thank you for the introductions. Welcome. I see a lot of you have joined us today. Brian and I are both so excited to share a little bit more about this study and engage with you and answer any questions that you might have either about the design or the research or the process of engaging both researchers and practitioners on a study together. Since this is the EBD Journal Club, I'm only going to do a really quick overview of the study and what we found, and then we can actually just launch right into the journal club portion and open it up for discussions using the chat box like Alan mentioned. So the idea behind this study actually began with an Institute for Patient-Centered Design challenge back in 2015, and this ended up being one of the award-winning designs for mental and behavioral health. We linked up with HDR, Cornell University, and the folks over at the VA in Lyons, New Jersey. This is a facility that previously has taken a plane tree approach in some of their existing designs and was really on board with the idea of bringing evidence-based design into their facility. Brian's on the call to fill in a little bit more about the design. So if you have questions about that, please feel free to jump in at the end. The objective of this study was kind of threefold. On one hand, we wanted to evaluate this mock-up and see how patients and staff felt about it. We wanted to facilitate that conversation between all of the end users in this facility and see if this mock-up might be a piece of that conversation. And then at a much larger scale, is there an opportunity to use full-scale mock-ups? What is their value in the larger health design research conversation? Many of you on this call, I'm sure, are pretty familiar with the challenges of mental and behavioral health design and some of the really kind of large existing gaps in research that we still have right now. In particular, one of the big gaps is that there really isn't that much research using full-scale, high-fidelity physical mock-ups in which patients and staff can walk through, provide feedback, and really engage with a design proposal before it's implemented. And whether or not this opportunity can be valuable, not just for practitioners, but also for researchers to understand some of the important considerations for larger mental and behavioral health design. As I mentioned, we had a wonderful facility partner in Lyons, New Jersey with the Veterans Administration. We used two methods here to kind of create a rich experience and a rich description of what might be going on in this facility. We used feedback forms, a pretty typical questionnaire, and listening sessions, which took the form of 3 focus groups, 2 with staff and 1 with patients. So participants included both patients and staff in both parts of this study. The feedback forms were pretty typical, asking about satisfaction with a number of different elements present in this mock-up. This was ranging from things like acoustical control and lighting, all the way up through whether or not the mock-up communicated a sense of respect for patients as well. So it kind of looked at qualities and characteristics along a larger spectrum. And we found some things in line with our hypotheses and some things that weren't quite what we expected. We did anticipate that there was going to be a difference in staff and patient evaluations, but we actually thought that patients were going to engage more positively with this mock-up than staff, and it was actually the other way around. Staff were overall more positive about the mock-up. Although both groups were quite positive in general, patients actually were more critical of particular elements, including respect, accessibility issues, issues of control and privacy, a lot of concern for comfort, especially surrounding certain furniture decisions, and then access to daylight. From the listening sessions, we also got some qualitative information about how people were actually responding to this mock-up. These listening sessions were kind of open-ended and semi-structured, asking a number of different questions about the experience in the space and with some of the particular elements of the mock-up. And through these conversations, 3 themes emerged. The first one, and kind of the most salient one, as I think you all might imagine, was safety. And this encompassed not just the safety of patients, but also the safety of staff. And a really important detail that emerged was this idea of patients being more concerned about the safety of their fellow patients than the safety of themselves. Deinstitutionalization is a key concept that's come up pretty frequently and is well supported across mental and behavioral health design literature. And again, as you might expect, it came up again here, especially in the idea of hominess. Often, these are facilities where family might not be involved. And so how do you create a sense of hominess in a space that is providing acute mental and behavioral health care? The idea of positive distraction was also very salient. In the absence of a lot of traditional entertainment options for safety reasons or otherwise, how do you still create a sense of positive distraction? And that's where the role of nature and views and artwork even played a role in the positive experience in this space. At At a larger scale, there was a conversation around this idea of a balance between control, privacy, and safety. How do we ensure that there is visual access for clinical staff while still allowing patients an opportunity for privacy and respite in the opportunity that they're not engaging with the group in group spaces at that moment? We know that privacy and respite is really important for healing, so how do we balance that with visual access and other safety concerns? And similarly, how do we provide patients with a sense of control in an environment that's not necessarily designed for patient customization and kind of the patient experience? How do we still make sure that we're communicating a sense of respect and control for patients in this environment? One of the other challenges that we experienced, and something of a takeaway in using full-scale mock-ups in the future, was this idea of the unpolished elements of the mock-up. Although the mock-up was full-scale, high-fidelity, things could be touched and interacted with, there were still some unfinished elements like exposed wiring, where a TV might have gone, and some exposed elements where lighting might have been, and a lot of the conversations became quite focused on these unfinished elements, which was in some ways a distraction, but in other ways a great example of why we need to engage end users throughout the design process, particularly in this kind of proposal step. Before we've built an entire unit, this might be a really valuable audience for evaluating the things that we might be trying to do as design practitioners. So overall, that's kind of what we found and how we did it. And Brian and I are open to chatting more about this. We have several photos of the mock-up as well in case you're interested in looking at something in particular.
Thank you so much. And now it is time, ladies and gentlemen, for you to ask questions of the authors. Please feel free to type in any questions you may have, and we'll try to answer them. Unfortunately, a lot of our questions so far seem to be around audio, which isn't super helpful for the content-wise. So I will jump in and start the process. Where did the design come from in the first place? You mentioned the design competition?
Brian, do you want to take that one?
Sure, I'd be happy to. So it was a design competition hosted by the Institute for Patient-Centered Design. The call of entries came out, I believe, in the spring of 2015. And then to be presented, winners of that competition would present at the Healthcare Design Conference that fall. And so we, as leaders in behavioral healthcare design, we thought we certainly need to become involved in this competition, and we need to do what we can to improve the behavioral health environment. We saw this as a perfect way to do that. So we got together as a small team at HDR out of our Minneapolis office where I'm based, and we designed what you see on the screen. We started to design this room, and we started to think about what were the aspects of the space that were often forgotten about, aspects of the space that are really institutional. What can we do to improve that? And so it built from there. And then we submitted to the Institute, and we were shortlisted as a finalist to present at Healthcare Design Conference in November of 2015, and then won the competition, which then opened up many doors to start working with people like Katie at Cornell, and some others working with the VA. And even as you see on the screen here, this cardboard mock-up was done at another conference as another way to start to explore the room in a low fidelity or maybe a medium fidelity manner. So a lot came of it. But it really all started with the Institute for Patient-Centered Design seeing this gap and asking professionals around the country to participate and try to improve this environment.
Cool. A lot of people are asking if there's any way to zoom in on some of the floor plans. I don't know if that's actually something that we can do strangely enough, in Zoom. But, there we go. Awesome.
Did that work? Okay.
Yeah, it did.
Let me see if I can zoom in one more time. Is that readable? I think it's kind of readable on my end.
Yeah, I can't see the words. Oh, okay.
I'm going to leave it here. Let's see.
All right, some of the other questions here while people take a look at that. How were all the elements of the design tested for safety?
So I'll take this one too. Some of the elements were already products that existed on the market that have already been tested and listed in some published design guides. So we knew that those were safe elements. We also, through the competition, we also had a series of sponsors. We had lighting sponsor, Visa Lighting, and a number of other sponsors for the competition that actually were interested in helping innovate in this area. So Visa Lighting provided light fixtures as sort of an exploration as we were doing this mock-up. They were also innovating on their end. Accurate Lock and Hardware was a fantastic partner in this because they actually developed a sliding door that you can see on the bathroom, the entrance to the bathroom. That was something that didn't really exist on the market. There wasn't a behavioral health quality sliding door that was safe, that was durable, was anti-ligature. And Accurate Hardware really stepped up to the challenge, and they developed a door. The first installation was actually at the mock-up, and then from that mock-up, they continued to manufacture this door, and now it's approved in design guides, the New York State Design Guide, and the Behavioral Health Design Guide published by Jim Hunt and Kimberly McMurray and David Sine. So I think that answers the question. The Ottoman was another product that actually was an innovative solution. OFS Brands was another sponsor for the competition, and they developed this Ottoman. We had sort of sketched this idea of a movable seating object, and it was round and it was colored blue, and that's really all we knew about it. But they saw this, and they saw a real opportunity to start to work with us to develop a solution that ended up having a sort of a weeble wobble base. It was weighted. We tested it, the amount of taper so you could get your heels under it to exit the chair, even putting a short back around it so that you could help use as leverage to get out of the chair. So there was so much excitement around this and so many opportunities for innovation, and there are so many more beyond what we've done in the last few years. You know, this is really what I see as the start of a new direction in behavioral health care and the amount of innovation and collaboration that needs to happen across the entire industry.
So we got a number of questions about the issue of windows, which also came up in the text of the paper. You mentioned that the original design of the windows, it had access to light but not to views of the outside, and that patients were asking for both at least a little bit of a view and the ability to crack the windows so that they could get some fresh air. Could you talk a little bit about those issues that came up around windows and why those were important to patients and staff?
Katie, do you have thoughts, or do you want me to take this one too?
Do you want to start, and I will kind of finish with any notes from the listener?
Sure. Yeah, that sounds great. So obviously we wanted a large window, and we wanted to provide a connection to nature because through our literature review prior to submitting this design competition, we really understood the importance of a connection to nature and natural daylight. Of course, I think intuitively we all know that, and the literature supported that. So we wanted to provide this connection. And then, of course, the idea of an operable window we felt was enhancing that connection even more by actually letting natural air enter the space, and you can start to hear what's happening outside. You really start to become much more connected when you remove, even if it's a transparent barrier, it's still a barrier. That barrier being the glass. If you can remove that in any way, you really start to create a better connection with nature, and that was our goal.
Yeah, and we found that with this, again, it was a compliant window that was allowable to open and close, and we found that both staff and patients responded really positively to the idea that you would get not only the sights, but also kind of the smells and the sounds of nature, and that was actually brought up pretty frequently in the listening sessions as a really positive element of this mock-up.
And in terms not just of the windows, but more broadly, I believe you mentioned a bit about ligature risk, but we've still had some additional questions about whether this is compliant with all of the VA regulations around ligature risks, whether it's a concern with windows that can open at all, functional windows, whether there were any in the bathroom, that sort of thing. Could you talk a little bit about what you did around minimizing ligature risks? And I suppose just in case there's anybody who doesn't already know on the call, what a ligature risk is.
Sure. So I guess we'll start with the basics. So ligature means that you're able to hook something onto it and create an attachment point. So that's harmful in mental and behavioral health environments because some patients may be a danger to themselves or others. So to be able to hook a bed sheet or a string or a rope or something around an object can very easily start to create harm or an opportunity for harm. So that's anti-ligature. Anti-ligature means you are not able to create points of attaching those objects. So broadly, yes, the room was designed with the intent of it being built to the highest standards of anti-ligature and durability and safety. We would have to go through and look at each element specifically and evaluate, the grab bars above the toilet and the light fixtures and the return air grills and the window and the desk and the ottoman, and the door, the sliding door, the door, the entry door to the patient. Everything would have to be evaluated. And we did to the best of our ability. Also, though, understanding that this was a mock-up, in Katie's presentation, she mentioned that there were some unfinished elements. And we knew going into this that would be the case. This was a mock-up that was done, built on volunteer time, donated by the VA with volunteer materials. So we certainly took great care in all of the aspects that we could to make sure that it was safe and there were no ligature points. In the end, that goes to the value of building the mock-up. We noticed a couple of gaps in areas that maybe weren't really safe or spaces where patients could hide contraband that once we built the mock-up, we thought, oh yeah, that actually is something that we need to look at a little bit closer when we do the full scale or do a real build where patients will actually be staying in this room overnight.
I think to your point, Brian,
go ahead.
That was another one of the wonderful values from doing the mock-up with patient feedback, that there were ligature points and other safety risks as well that we might have not noticed on our end that were very apparent almost immediately to both the staff and the patients who walked through the room. And it was a really effective way to get feedback on something that we might not necessarily notice right away.
Absolutely.
Well said.
A lot of questions around the counters in the window seats, about the design of them and whether they're made of hard or soft material and any risks associated with them.
Yeah, I'd be really happy to talk about that one briefly. The countertop that you can see in this image that wraps the perimeter of the room and then it actually slopes up to form the desktop surface is solid surface material, and it is one continuous surface. And by creating one continuous surface, we're actually starting to create a safer environment because you have fewer points of a material ending in a new material beginning, or the edge of the desk or the end of the desk, which could be a sharp corner and an opportunity to start picking at. So by eliminating these transition of materials and ends of objects and beginning of new objects, you start to eliminate some of those risks that are just inherent in everyday life and furniture design and everything else if it's just a standalone object that you put in the room. But by building this in, now it's permanently fixed to the wall, and it is continuous. It is hard, and it sounds maybe like it would be uncomfortable. I was incredibly pleasantly surprised to see, actually experience how comfortable it was to sit on the solid surface bench. I honestly, it was an odd feeling. It felt like I was sitting on something that had a little bit of give to it, even though it was a very hard surface. And the fact that it did have the slope, we knew we wanted a slope mostly for the ability to eliminate that transition. But we also thought it would be an opportunity for lounging, and that slope is actually incredibly comfortable to just lean up against and lounge on. One of the comments that we received from one of the psychologist that was touring the space said that it would be great if it could actually slope up in the other direction also, because it's natural for us to put our dominant side towards the window. So if you're right-handed, you would naturally want to do with your right hand towards the window, left-handed to with your left hand towards the window. And that was a fantastic suggestion that is something that we wouldn't have had if we didn't build this mock-up room. So, it's a really nice feature to have in the room, and it's something that we try to incorporate now in a lot of our design solutions that are built around the country.
Getting questions about it. You mentioned it felt like it had a little give to it, but we're getting still a lot of questions around, is it soft at all? I do remember in the paper you mentioned that a couple of people gave feedback that maybe you would want a beveled edge on it. It's a hard, maybe I'm not understanding the question. It's a hard surface. The edges are rounded. They're not sharp. You can't cut yourself on them. Of course, there is an edge, and edges can be dangerous. And there were some individuals that toured the space that thought maybe we could round the edges even more and soften them up a little bit more. But overall, that didn't seem to be a big concern, at least from the evidence that I heard listening to people talking about the room. Now, one of the things that you mentioned in the paper is that you had to build this mock-up in an existing facility, and that there were things about the room that you weren't able to change because you were building it in this existing space that was going to go back to them when you were done with it. So could you talk a little bit about what had to remain the same and what might have been done differently if you had full control over the space?
Sure. So what we're looking at on the screen now, it's really a room inside of a room. There's actually you can't really see it in this image because of the exposure coming through the windows, but there's probably a 3 or 4 foot gap between that wall, which is a stud wall with drywall on the inside face of it, and then the actual exterior wall of the building. So this was in a large meeting space that some of the vets used regularly, but they were so excited about this project that they wanted to give up their room to let us use it for this purpose. So this is built inside of another room, and we did not touch the floor and we did not touch the ceiling other than install the light fixture and the soffitting that you see in the ceiling, because we knew at some point we'd have to give it back, and that was an expense that we didn't feel was necessary to convey the intent of the design. It would be great to have a sheet good flooring that we would use with an integral cove base and all of that, and then of course a hard ceiling in the room without the sprinkler heads that you see poking out of the ceiling. But those were things that we thought we could leave as is, just for the sake of it being a mock-up. So really, if you ignore the ceiling tile, you ignore the very dangerous looking sprinkler heads that are sticking out of the ceiling, and you ignore the old tile floor that you see and the base around just a simple rubber base around the floor, the perimeter of the wall. If you ignore those elements, the rest of it is really pretty much built the way that we would want it to be built, and built the way that we had initially designed it.
Fantastic. Now, one of the issues that you mentioned and that came up in the paper and that some people have asked about is about the ability of the patients to control things in this space, which is, an element of being homey, I think, controlling lighting, etc. Could you talk a little bit about both what was in the design that people liked, that they had control over, but also about what came up in the discussions with people about what you might want to do in future designs?
Sure. So there were. Oh, go ahead, Katie. I want you to start this one.
Okay. All right. So in terms of control, there were some things that we came in with that the mock-up was built with. In particular, this ottoman actually served as kind of a nice sense of being able to control the social interaction in the space, move some furniture around in a safe way as well. The window opening actually has a sense of control as well. The sliding door to the bathroom, privacy, even though it is its own element and has its own considerations, is also wrapped into control as well. How do you regulate your social interaction? How do you have control over your visual and social access in a space that's designed to be surveilling you? So the sliding door was a kind of really unique element that was, I think, overall positively responded to as a sense of providing dignity and respect, but also control in that way. Brian, do you have any other things that kind of pop out to you?
I think you hit the big ones. Really, the whole design was about providing control and choice and empowering the patient. And we really, from a design standpoint, we asked the question a lot while we were designing. Well, if this was your bedroom, what would you have control of? Could you, in your bedroom, when you go home, in your bedroom, can you move the furniture? Can you shut the door on your bathroom? Can you, do you have the appropriate space to store your belongings? Can you choose where you store your belongings? Can you choose what type of artwork you put in your room? All of these, these were just questions. What is it? If we were kind of wondering what we should or shouldn't consider, the question was, well, what do you do? What's in your bedroom? Because that's what this is. This is a bedroom for patients who are away from home. Of course, the caveat to that is we need to be very sure that the decisions we're making are safe for the patients and staff. So, we can't just you can't just take your bedroom at home and put it in here. But it's the idea of providing the same or trying to reach the same level of control and choice in the environment as you would at home, using that word hominess, right?
Mm-hmm. And that gets to another question that's come up from our participants and that came up in the paper, and that is about single patient rooms and maybe the potential downsides of making them too nice and homey so that people don't want to go out and interact, which is part of the therapeutic process in mental and behavioral health facilities. What were your thoughts on that?
Sure. Speaking of lighting, I'm sorry for the glare that's coming in through the window here. So one of the real benefits of using the mixed methods that we approached this research study with, so we looked at both the feedback forms in a quantitative way, but the listening sessions as well in a qualitative way. And those listening sessions helped reveal some things that we didn't necessarily see if we were just looking at the feedback forms. And so one of the things that came up in the listening sessions, this is quite bright, sorry. One of the things that came up in the listening sessions was this idea that maybe there's something unique about the VA population, especially in this acute mental and behavioral health facility. There is a concept for a lot of the returning veterans, this idea of battle buddies, that there is a companion that you have with you kind of throughout your trials. And that concept actually kind of became illuminated in these listening sessions as well, that there is a sense of responsibility to ensure the safety of the person that you might be sharing a room with. And so there were really mixed reviews, both from patients and from staff, in terms of whether a private room or a shared room was appropriate. But one of the big reasons that stood out was this idea of kind of shared responsibility and fellowship through the acute mental and behavioral health treatment process, and whether there's value in having a shared room in that sense. And Alan, I'm gonna close this window. So Brian, if you have anything else to add, I'm gonna sneak away for a second.
I think that's great. I'll take the next question.
We got some questions about whether there were any pictures of the bathroom area.
Oh, I think so. What order they're in, I'm not sure. So give me one moment to. I think this is probably the most high quality image we have of the actual mock-up of the bathroom, at least the sink area. So I'll leave that there for a second, and then I'll look around and see if there's any other ones.
We had a question about why you went with the open shower concept as well.
Sure, I can take that one. The main driver with the open shower concept is safety. With the open shower concept, you eliminate a risk or you eliminate the need for a shower curtain or a barrier that prevents water from splashing into other elements of the bathroom. So that creates a safe opportunity because you no longer have a curtain that's potentially dangerous that a patient can tear down or rip down. You don't have hooks that the curtain attaches to. You don't have a rod that the curtain attaches to. There are some products on the market that are advertised as being safe, and I'm not going to say whether they are or not. That's not my place. But by not using them at all, it seemed like the appropriate solution, because then you eliminate the question of whether or not they're safe. And so that's really the main driver. There were some comments about having that additional layer. If a patient is in the bathroom taking a shower, they would just feel more comfortable if they had an additional layer of separation. If a provider were to have to come in for some reason, just the one barrier on the bathroom door itself maybe just wasn't enough to create comfort for the patient. But the open shower concept is becoming much more common. And the biggest challenge that at least that I've noticed recently is the water splashing out of the room. And that, you really accomplish that through sloping the floor correctly and drains and pointing the shower head in the appropriate direction so it's not blasting straight out of the room. So it's certainly a doable solution. You just need to be careful. And then also thinking about positioning the other fixtures in the room, the sink and the toilet. And if you can actually walk to the sink or walk to the toilet without having to walk across a wet floor. So thinking about that too as you're designing the shower and the location of the shower head and the direction of water flow.
Thank you. What was the feedback from the patients related to respect and empowerment? Because that was the area where it scored lowest. But what were the actual issues that they raised?
So I think kind of lumped into respect and empowerment was a lot of other dimensions of this space. So under the umbrella of respect, we have things like control, privacy, and the provision of entertainment and positive distraction. So all of those things are lumped under this umbrella of respect. Some of the specific things that came up, I think, that contributed largely to some of those negative reactions were some of the accessibility issues. There were some patients that were substantially concerned about whether this room was a good fit for the elderly or disabled population, whether some of these elements made sense, particularly for elderly individuals. Could the ottoman even be moved by someone with mobility impairment issues, and was it even valuable to have? And other things like the ability to choose where you store your belongings or choose how you sit in the room. So again, all of these things that go back to choice and control are lumped under respect. Some of those things were successful, and I think in the negative elements, we got some good feedback from the mock-up.
What were some unexpected things that you learned from the mock-up?
I'll go first, Brian. I'm sure you have yours as well. I think overall there's a kind of a large body of research that suggests that patients usually respond more positively to just health environments in general. Patients respond more positively than staff. And so to find that staff actually responded more positively to this environment was really contrary to a lot of existing literature. And we have a couple of theories why that might have happened. Staff were really bought into this idea. We had a fantastic facility, and staff were really engaged and kind of championing this idea of a new patient bedroom. So I think there was this excitement and overall kind of positive enthusiasm about the space that trickled into those feedback forms. And maybe patients weren't necessarily, they were just more critical because this was an acute mental and behavioral health facility where safety concerns were far more salient than in a lot of other health environments that you might be asking for feedback on. And so those safety elements almost kind of trumped other positive elements in this space, and that made the patient evaluations kind of more negative than staff. So that was the big unexpected finding on the research end.
Sorry, was the question what did we learn from the mock-up?
So what were the unexpected things that you learned from the mock-up?
Sure. So the biggest unexpected thing that I learned was really that you have to build mock-ups of behavioral health rooms. I think that was the biggest takeaway for me. I think that it's something that we always try to do and we talk about doing, and we may mock it up in cardboard, which is great to get a sense of space, but to actually build it, to really build it with real materials, you start to notice the little things that really you can't see in a two-dimensional floor plan or a section or an elevation view. You can't even see it in a 3D rendering because it's not drawn to complete 100% detail, right? So until you actually build it, that's when you start to notice the corner of, we're in this image that I'm looking at here, that sort of where the desk tapers off towards the toilet room. That corner could be, if I remember right in the mock-up, there was just a tiny little gap at the edge of that starts to create a potential point for either a ligature or the ability to cut something on it. So just being able to see the entire thing built one time, especially if you're going to be replicating this room, 16 or 32 or 64 times or more in a facility, you want to make sure that you get it absolutely 100% right the first time. Because if you don't, and you don't thoroughly evaluate it, then you're going to have a challenge. Potentially a very dangerous incident could happen that could be avoided if you'd spent the time and effort on mocking up a single room.
And Alan, I'll add to this as well. You had mentioned earlier there was a question about private versus shared bedrooms. And we noted in this study that this is obviously part of a much larger conversation about private versus shared rooms in a number of different healthcare domains. But in particular, I think it was a little bit unexpected on our end that there was some positive feedback about having potential shared rooms. This was obviously a mock-up of a private bedroom and a private bathroom, and that was overall really well received. That goes into the idea of privacy and control over your own space. So I think we were surprised. Obviously, we expected that staff were going to have a concern about visual access and supervision with private rooms, but that patients also, in some ways, shared those same feelings as well. And I think that was an important piece of information that is a huge jumping off point for future research, especially in acute behavioral health facilities where supervision is important.
So we got some questions about the cost of materials, and because mental health grade, behavioral health grade materials, fixtures, et cetera, are more expensive than the standard. Did you factor that into your mock-up process, and what did that look like?
You want me to take this one, Katie?
Yes.
Great. Okay. So going back to the design concept, this was, or the competition, this was to create the ideal behavioral health patient room of the future, to create an innovative solution for the future. And so going into it, because we approached it, you don't have a budget, you don't have a project schedule, you don't have specific guidelines or standards that you have to follow. Design this to be the behavioral health space of the future. So as far as cost goes, we weren't on a budget, so we didn't necessarily consider this grab bar costs more than this grab bar, so we're going to use A instead of B. During the installation, the construction and installation of all of the accessories and fixtures and finishes, we started receiving donations from suppliers. So we have a list of 30 or so suppliers that actually donated their product to be installed because they wanted to test it or showcase it, or they just felt that this was the right thing to do to improve behavioral health care. So the donations were incredibly important, and this wouldn't be what it is without them. So thank you to everybody who's listening that donated anything to this mock-up. It really is. It's it couldn't have been done without your help, and this was done on zero budget. So we had to use every bit of donation that we could.
And that brings up another question that someone asked, which is a great segue really, is what aspects of this design are new and innovative?
Oh, yeah, that's a really good question. So I think it's starting to think about the elements in the room was the biggest one. It's working with the manufacturers to create solutions. So the sliding door in the bathroom is something that hadn't been done before. This weighted ottoman that you see in the image here hadn't been done before. It's now both of those are now on the market. Engaging the lighting manufacturers starts to create a more innovative solution. And then I think the things like providing a connection to nature through a digital artwork display, that's not necessarily innovative because we see that all the time now. You have a display screen and you can select what you want. But to incorporate that into a behavioral health patient bedroom is something that hadn't been done before that we know of. And it's something that we felt was necessary to provide that additional connection to nature and control and choice. I think as a whole, it's starting to become a model that is being used now to advance the future of behavioral health design. Not that this model is the right solution, but that it is inspiring further research and further study on advancing behavioral health patient room design. So it's hard to pinpoint exactly one innovative thing about it. I think as a whole, it's starting to transform the industry. And when you think about innovation, it's really about transforming. and going beyond what's currently been done.
And I'll add to that because you made this point, Brian, that this room isn't necessarily a guideline in and of itself, but that a mock-up is a way to test potentially new, innovative furnishings, seating options. So while we're not presenting today a comprehensive set of design guidelines for mental and behavioral health, those actually exist. There's certainly still research to be done, but those exist. This room was constructed largely under those guidelines, but the value of this study was that we're evaluating a mock-up that has some additional elements that might not be included in those design guidelines, but could potentially really improve quality of life while still ensuring safety.
Mm-hmm. Were there any differences that you ran across in terms of the perception of the room on the basis of patients' age or gender? I mean, I know very male population in the VA, but the female veterans, women have a very different experience, both in terms of the traumas that they experience in the military in many cases, and some great work almost locally here in LA's VA on their experience at the VA. Did they have any different experiences of the room?
So our mock-up participant pool was actually almost entirely male. There was some acknowledgement, both on the staff and patient side, that it would have been great to have kind of more of a female perspective on how this room might function. That was actually one of the limitations in our study and something that I imagine future research would show. We know that there's differences in the way that men and women regulate their privacy. There's differences in the way that men and women create a sense of territoriality in their space. And so future research would definitely benefit from looking into gender differences. Brian, do you have anything to add?
No, I think you covered it well. The participants in the study were primarily male, so we didn't have the opportunity to hear the other opinion. I guess one thing I will add, I already mentioned it, the shower, the issue of an added layer of privacy in the shower was brought up by at another event that we presented this concept at, the cardboard mock-up event. This was brought up that maybe it wasn't enough privacy for somebody with post-traumatic stress and wouldn't feel comfortable showering in that type of environment. So I think there are, aside from that, I don't know that we had any other specific feedback from females, but that's certainly something that we should explore.
What were the things that people liked the very best about this room mock-up?
Things that were evaluated most positively. I think overall people were pretty pleased with the access to daylight, pretty pleased with the windows overall, and the acoustical control in the space, that it wasn't particularly loud, which is important when you're talking about acute mental and behavioral health, that there was a sense of still daylight and window light, but not a ton of acoustical intrusion. Overall, patients were actually pretty pleased with the comfort of the room. I think the furniture had its positives and negatives, but I think patients were overall really appreciative of as Brian mentioned, the innovative nature of this countertop space, that it might serve as a desk area, a lounge area, an alternative seating area. So as a more abstract element, just the creativity and the thought that went into this room was really well received. Anything to add, Brian?
No, I think it was exactly that last point, that people really appreciated the study, and they were sort of just in awe of the thought, especially the patients that toured the room were just in awe that the people were actually thinking about it to this level of detail. So different people love different elements of the room. I don't know if there's one that really stood out to me as the absolute favorite.
Were there any issues where you ran into the current behavioral health room guidelines as barriers to what you thought was the best thing to do for people in the design of the room?
Not that I can think of. I think the guidelines are written in a way that provide enough flexibility to do what we wanted to do. We really designed this with FGI guidelines in mind and making sure that we weren't doing something that wasn't approved, providing enough space around the bed and things like that. So I didn't feel any barriers. I didn't feel that we were trying to do something that just wouldn't be accepted because of the guidelines. This wasn't, when we did the competition, we didn't design it to the VA standards because we didn't know that this was going to eventually be installed at the VA. So we really didn't use those strictly. We certainly reference those when we're designing as we do any other document, but FGI was our primary source as we designed this room.
Okay, second to last question here, because we're running out of time and we've got so many great questions. We got several questions about the digital artwork, how it's mounted, protected, and whether they have any control over it.
Yeah, so very, very quickly, the digital artwork display in the Mockup was actually installed. It's a TV screen, a flat screen TV recessed in the wall. It's a gypsum board wall recess, and then it has holes in the back of it to provide some ventilation. And then the front is covered by a clear plastic cover that's then screwed into the wall, and with it's sort of recessed so that there are no edges. And then, of course, there's pick-proof sealant around the perimeter of that, and then a few holes drilled in the front of that to allow for ventilation and sound if it were to be used as a TV.
And finally, if other people wanted to follow your excellent example of conducting a user-centered mock-up study for mental and behavioral health rooms, what tips would you have for them? Because really, as you mentioned, this probably should be the standard of practice for something as safety critical and important as behavioral and mental health rooms.
So I'll let Brian add his perspective on at least the design process and his tips in terms of this mock-up creation. On the research side, I think there's substantial value in the actual physical full-scale mock-up. There's a great deal of work right now in VR and using virtual reality as a proxy for evaluating design proposals and mock-ups. And I think there's certainly a wonderful space for those to exist, especially when we're talking about budget constraints. But there really isn't anything that compares to being able to identify that spot in the corner where the shelf isn't necessarily connected to the wall, or using this new innovative sliding door, or moving around a potential really innovative solution to an ottoman. So I guess my tip is more of a word of encouragement that there's a ton of value in the creation of a physical mock-up. And if there is anyone out there funding this research, I think that goes a long way to making sure that this is the standard of design research when we're talking about really vulnerable populations.
Yeah, that's great. My tip, I'll leave it to one tip for the sake of time, is to include everybody, include as many people as possible, and not just numbers, but different perspectives. You need patients, you need staff, you need designers, you need people who are going to come in and clean the floors. You need every single person who may be involved. You need patients, you need family members, you need advocates. patient advocates. You need everybody that you can to be involved in this process, because everybody has a different angle on how they're going to look at things and think about things, and it's all valuable, and it all comes together in a way that can really help to inform the future of behavioral health design.
Thank you both so much for sharing this excellent work with us. And thank you also to the Health Environments Research and Design Journal for providing free access to the articles we discussed. Please be sure to subscribe to the journal using the code HERD20 for 20% off of the subscription cost. Thanks also to Pat Kraft for supporting today's Evidence-Based Design Journal Club. Please check out, that is not what I'm going for there. Please be sure to check out the events page on the Center's website to see a list of upcoming events. We have a behavioral health design workshop, very relevant, in Los Angeles on May 21st. Thanks very much, Katie and Brian, for sharing your research study. This concludes our event. We'll leave the webinar open for another 15 minutes so that you can download the EDAC and AIA CEU forms. Thanks again for joining us, everyone, and have a great day.